All right. Now, atherosclerosis is a buildup of calcium and cholesterol in the arteries. And once that starts to occur, as you can see in the diagram, the diameter of the artery will become narrow. And as it starts to become narrow, it means the pressure inside that space when the blood is flowing is going to increase. So the patient is actually going to start developing high blood pressure as a result. Now, athero with the ATH, sclerosis, is buildup of cholesterol and calcium. So this is the fatty stuff. Over time, that will become arteriosclerosis. Over time, the buildup will harden and plaque will start to form. When it hardens, it becomes arteriosclerosis. Know the difference between the two terms. So ATH is the fatty buildup. ART is when it hardens. Now, if it hardens over time and the patient has a high blood pressure that's not controlled, what can happen is that pressure can cause a piece of that plaque to rip off. And when it rip that plaque off from the wall, it plugs the artery and the patient gets a heart attack. That's how a heart attack occurs in the coronary vessels. So ensure that you know the difference between atherosclerosis and arteriosclerosis. A thromboembolism is a blood clot floating through the blood vessel. So you will come across the term thrombus and embolus. Both represents a clot. A thrombus is a clot that forms in the area. So like how I just explained the clot forming in the coronary artery, that's a thrombus. An embolus is a clot that forms somewhere else in the body and then travel to a location. So for instance, embolus forms in the venous system, travels to the right side of the heart into the pulmonary vessels. That's an embolus. But both represents a clot. It's just that one travels and one forms in the area. If a clot lodges in a coronary artery, the patient is going to get an acute myocardial infarction. When a patient has a heart attack, you must anticipate three things occurring. So always anticipate three things occurring. These are things that will commonly occur. So within 2 hours of a MI, the patient can go into cardiac arrest. That's one. So they can go into pulmonary arrest or sudden death within 2 hours. The patient can develop congestive heart failure, and it can be right side dominant or left side dominant. That's 2. 3, the patient can develop cardiogenic shock. So these are 3 things that you must anticipate occurring in your patient if you suspect an MI. Sudden death, congestive heart failure, and cardiogenic shock. Coronary artery disease is a leading cause of death in the United States. Controllable AMI risk factors include cigarette smoking, high blood pressure, high cholesterol, diabetes, lack of exercise, and obesity. Uncontrollable AMI risk factors include older age, family history, atherosclerotic coronary artery disease, race, ethnicity, and being a male. Acute coronary syndrome is caused by myocardial ischemia. Remember the term ischemia means a decrease in blood flow. So when there is myocardial ischemia, it can lead to angina pectoris, which is chest pain, or it can be attributed to an acute myocardial infarction, which is a heart attack. Angina pectoris occurs when the heart's need for oxygen exceeds supply. So if the patient is doing an activity, suddenly activity that demands a significant amount of cardiac output and they're not used to that activity, it can lead to chest pain or angina pectoris because the activity exceeds the demand of the cardiac output. But when they relax for about 10 minutes, the pain subsides. That's angina pectoris. It can also be caused because the patient has atherosclerosis. So the coronary artery is narrow, and every now and then it pinches shut, and enough blood is not feeding the heart, and they start to get chest pain. But when they take like a nitroglycerin tablet, it opens up the vessel, and they're able to get blood to the heart, and the pain subsides. So it can occur two ways. So angina pectoris occurs when the heart's need for oxygen exceeds supply. Can cause crushing or squeezing pain. Some persons will describe it as increased pressure, which is very common in the chest. It does not usually lead to death or permanent heart damage. Should be taken as a serious warning sign. Now, unstable angina occurs in the absence of significant increase in oxygen demand. So I explained two ways. You have the angina pectoris where the person is exceeding the demands of the heart because of physical activity. And then you have the angina pectoris where it's because of the clogging, the buildup of cholesterol and calcium in the artery. It's not brought on by any increase in activity. That's unstable angina. Stable angina occurs in response to exercise or activity that increase demand on the heart muscle. Know the difference between the two. So one is as a result of increased physical activity that exceeds cardiac output. That's stable angina. Once they rest, pain go away. Unstable angina is a patient that whether he's carrying out physical activities or not, because of the narrowing of the coronary artery, the passage can become so narrow at times that it reduces the amount of blood that is feeding the heart and they get chest pain. Treat angina patients like you would treat a patient with a heart attack or AMI. AMI pain signals actual death of cells in the heart muscle. Once dead, cells cannot be revived. Clot-busting thrombolytic drugs or angioplasty within the first few hours prevents damage. So with the cardiac muscle, time is muscle. The sooner the patient can get intervention, the better for the patient. Immediate transport is essential. Now, signs and symptoms of an AMI. Weakness, nausea, sweating, chest pain, discomfort, or pressure. Pressure is common. Lower jaw, arm, back, abdomen, or neck pain. Irregular heartbeat, and syncope, fainting, which is common in the geriatric population. Shortness of breath, dyspnea, that might be the only complaint in the geriatric population. Nausea, vomiting, pink frothy sputum, sudden death. And the pain for an MI will not subside after 10 minutes. It's going to go beyond 10 minutes and it's going to increase in intensity. So it's not intense from the onset. It's going to gradually become more severe as the area of damage spreads. So if a patient tell you that they're having severe pain, chest pain from the onset, that ain't an angina, that's something else. And listen to how they describe the pain. AMI pain differs from angina pain. It is not always due to exertion, lasts 30 minutes to several hours, not always relieved by rest or nitroglycerin. AMI patients may not realize that they are experiencing a heart attack. AMI and cardiac compromise physical findings. So look for fear, nausea, poor circulation, faster, irregular, or bradycardic pulse, decreased, normal, or elevated blood pressure, normal or rapid and labored respirations. Patient may express feelings of impending doom. They may literally tell you that they feel like they're gonna die, or they don't feel well. They don't feel like they're gonna survive this at all. Now, I've mentioned this before. If you suspect that your patient is having a AMI, anticipate 3 things to occur. And as much as I am saying it over and over, when you guys come to your practical session, you're still not going to be thinking about it. But anyway, I will reinforce it. 3 consequences of an AMI. Patient can go into cardiopulmonary arrest within 2 hours. Patient can develop cardiogenic shock, which simply means that the heart muscle is so damaged that it loses 40% of its cardiac output. So you can have a patient with signs and symptoms of a heart attack and a low blood pressure. That's cardiogenic shock. Or the patient can develop congestive heart failure. We saw that in the question, right? So the patient can develop congestive heart failure, which will either be dominant on the right side or dominant on the left side. If it's dominant on the right side, they'll have distended neck veins, enlarged liver, fluid in the lower extremities. If it's dominant on the left side, they're gonna have fluid in the lungs, pulmonary edema. They can have both occurring at the same time because it's a connected system. So if the right side fails and it's not corrected, the left side will eventually fail. And if the left side fails and it's not corrected, the right side will eventually fail. It's a closed network. Now, pathophysiology, dysrhythmias. Dysrhythmias may occur in cardiac patients. Dysrhythmias are heart rhythm abnormalities. They can have a premature ventricular contraction, which means that the ventricle is contracting before it should, premature. They can have tachycardia, where the pulse rate or the heart rate goes above 100. They can have bradycardia, where the heart rate goes below 60. They can have a tachycardia that is being generated from the ventricle, which not supposed to occur. That's abnormal. This tachycardia is too fast to sustain adequate cardiac output. Now, a patient with ventricular tachycardia can have a pulse, or the pulse can be absent. So they can present with a pulse, but if it's not corrected in a timely manner, the pulse is they're gonna lose that pulse. A patient who has a pulseless ventricular tachycardia You treat that patient as how you would treat a patient in ventricular fibrillation. So in other words, there are two rhythms that require defibrillation: pulseless ventricular tachycardia and ventricular fibrillation. I've already explained ventricular fibrillation. Once you see fibrillation, there is chaos occurring. Each cell is trying to generate its own impulse, and it's not strong enough to create a heartbeat that you can feel on the patient. So the patient is in cardiac arrest. CPR, use of an AED is required. So defibrillation restores cardiac rhythms. It can save lives. It initiates CPR until a defibrillator is available. So when we do CPR on a patient, it is to buy time until an AED, automated external defibrillator, or a manual defibrillator is available. Asystole is what you would refer to as a flat line. So asystole is a flat line. We see that a lot in the movies. And we see a lot of people coming back from asystole, which is a misconception. So when a patient has a flat line or asystole, it means there is no electrical activity present. The electrical activity is gone. And this is a rhythm that doctors will call the code on. So this is where they will pronounce the patient dead based on the time, right? So this is an indication of no electrical activity. And contrary to what you might see in some of these shows, you can't defibrillate no electrical activity. There's nothing to defibrillate. All right, now cardiogenic shock, often caused by a heart attack. That's one of the primary causes. Heart lacks power to force enough blood through circulatory system. Inadequate oxygen to the body tissues causes organs to malfunction. Recognize shock in its early stages. That is your goal. Covered all of that last week. Congestive heart failure often occurs a few days following a heart attack. So again, people, congestive heart failure cannot be acute. It would be chronic. Often occurs a few days following the heart attack. Increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart function. Lungs become congested with fluid, and it may cause dependent edema. If they are having dependent edema, which is fluid in the lower extremities, then the right side has started to fail. If they have fluid in the lungs, this patient is going to benefit from CPAP. So if you're going to give them oxygen, you should consider using CPAP to administer that oxygen to push fluid out of the lungs. Now, hypertensive emergency. This is defined as in your text as a systolic pressure that is greater than 180 millimeters of mercury, with signs and symptoms which include sudden severe headache, strong bounding pulse, ringing in the ears. Or in layman terms, it's a blood pressure that is so high that it causes systemic complications. Common symptoms: nausea and vomiting, dizziness, warm skin, dry or moist, nosebleed, which is a common occurrence with patients who have uncontrolled high blood pressure, altered mental status, sudden pulmonary edema. If untreated, the patient is going to be at risk for stroke or a dissecting aortic aneurysm. Transport patients quickly and safely. Consider ALS assistance. Now, when you are obtaining a blood pressure for a patient, always let it become consistent that you also check for a pulse pressure. I didn't say a pulse rate, I said a pulse pressure. So get in the habit of obtaining a pulse pressure when you check a patient's blood pressure. That will tell you the force of the patient's cardiac contraction. Now, the aortic aneurysm. An aneurysm is a weak point in the artery. So if a patient has uncontrolled hypertension or high blood pressure, which is the most common cause, over time, the high blood pressure can rip away plaques, and it can also create a weak point, a weak area in the walls of the artery, and that is referred to as an aneurysm. It can, with that weak area, two things can occur. It can rupture, or the walls can start to split or dissect. So two things can happen when they have an aneurysm. The aneurysm can rupture, the weak point can rupture, or the wall can start splitting in two or dissecting. This patient is gonna present with severe pain from the onset. So the pain will be severe from the onset. The patient is also going to describe the pain as a tearing pain. They will describe it as a tearing pain. And this is a patient in which when you check the pulse on the right and compare it to the pulse on the left, they're gonna have two different pulses. If you do a blood pressure on the right arm and do a blood pressure on the left, you're gonna have two different blood pressure. Very unique to this patient. So signs and symptoms: very sudden chest pain, severe from the onset, comes on full force, difference in blood pressure. So if you do blood pressure on the right and do a blood pressure on the left, you're gonna get two different readings. May be difficult to tell the difference between a dissecting aneurysm and an AMI. Transport the patient quickly and safely. And if you can't tell the difference, this is where you need to consult your medical director, because some of the treatments that you would use for an AMI, you cannot use it for a dissecting aneurysm. If you do, you're gonna kill the patient. So you can give nitroglycerin to an AMI patient. You can't give that to a patient who have a dissecting aneurysm. You're gonna kill the patient. So if you're not sure, seek guidance. That's the purpose of medical direction. Now, this table 17-2, outlines the difference between AMI and dissecting aneurysm in terms of how the patient will present, and the OPQRST, things that they will complain of, or things that might be present. All right, now patient assessment. Scene safety. Ensure the scene is safe, follow standard precautions. Nature of illness, obtain clues from dispatch, the scene, patient, family members, bystanders. After you've completed your scene size up, which is ensure that the scene is safe, take standard precautions for yourself and your teammates, identify nature of illness, how many patients, whether or not you need additional resources. And if you need additional resources, request these resources early. Next phase, primary assessment. Purpose: to identify immediate and potential life threats and address them. It is not to do vital signs. Don't let me see you doing that nonsense. Form a general impression of the patient and the environment. If unresponsive and not breathing, begin CPR, call for AED once it's indicated. Assess airway and breathing. Oxygen saturation less than 95%. So if it's less than 95% and still above 90, low flow is preferred. So note this slide. Low flow is preferred. So do not give a patient with an MI high flow oxygen if it is not needed. You're going to cause more damage than assist the patient. It goes back to the anatomy and physiology. The red blood cell cannot hold more than 4 oxygen molecules. And if you break down the percentage, you're gonna understand why you don't need to go high flow. If I have a patient, cardiac patient, that has a pulse ox of 90% on room air, showing a little difficulty breathing. A nasal cannula is 24 to 44%. So with each liter, you're basically adding roughly 4%. So if I give this patient 1 liter, that's 24. 2 liters, that's 28. 3 liters, that's 32. 4 liters, that's 36%. 36% is more than sufficient to add to 90. So the patient doesn't need high flow. So I wouldn't even go with a 4 liter. I would go with 2 and gradually go up if I need to. Right? So don't give them oxygen unless it is indicated. If their cells are already oxygenated, you're going to create free radicals that can damage the oxygenated cells, and you're going to cause the coronary artery to vasoconstrict. And we don't want the coronary artery to vasoconstrict. We want it to stay dilated. So again, assessment is very important. And this is why I get annoyed and frustrated, even though I shouldn't, when I have a EMT that has been out there for 2 years and come back, and I give you a patient, and before you do any type of assessment, I just simply said to you that, okay, you can see that the patient is having trouble breathing, right? The patient look like they're having trouble breathing. The first thing you decide to do is put on oxygen on the patient. You haven't assessed anything. You haven't considered anything. That's madness. Absolute madness. You cannot manage something that you have not assessed properly. So your assessment of breathing is essential. Assess the ABCs properly. Look at the pulse ox on room air. Consider the presentation. If you suspect MI, start with your low flow if oxygen is needed. Gradually increase as necessary. For patients not breathing or with inadequate breathing, you know that you're going with your 100% oxygen with your bag mask device. If the patient has pulmonary edema, your BVM or CPAP is what you're going to use. BVM if the patient is not responsive, CPAP if the patient is responsive. Very important slide. Extremely important. All right. Now, after we have assessed and managed breathing issues, the next phase of your assessment is circulation. Check the pulse. Patient talking to you, peripheral pulse. Patient not talking, radial pulse. Check skin, capillary refill. Consider treatment for cardiogenic shock. Make your transport decision. And again, once you have completed your assessment of the ABCs at this stage. You should know the patient's GCS. You should know if you need to do a rapid scan or you need to focus on the system involved. You should know if it is a load and go patient or a stay and play. Make your transport decision. Decision based on ability to stabilize life threats during primary assessment, transport in a stress relieving manner. Be careful with your lights and sirens. Be very careful. Now, once you have packaged the patient again, and I'm going to continually emphasize these things, and even though I'm doing it, there will be chaos when we meet face to face. Once you get the patient to the back of your unit, if the patient is talking, get information from the patient, then your vital signs. Patient not talking, consider your physical findings, then your vital signs, then think about who you can get information from. In your vital signs, make sure you include pupils, pulse ox, blood sugar. In a history taking phase, investigate the chief complaint, example, chest pain, difficulty breathing. Obtain a sample history from a responsive patient. Use the OPQRST to get more information on the signs and symptoms, or use the OPQRST to get more information on the presenting problem. All right. This table shows you a few things that you can ask based on the OPQRST. Review it. All right. Now, after the history taking phase, we're into the secondary assessment. And that secondary assessment can be a focus assessment or a detail assessment. And once it's a focus assessment, you're going to focus on the systems that are being affected. And for this patient, it's going to be cardiac and respiratory systems. You will obtain your vital signs. The vital signs that we are taking at this point is to compare to the findings in the primary. So if you have given any treatment, what was the findings before? What was the primary assessment findings before treatment? What is the primary assessment now after treatment? Is my patient improving? Is my patient getting worse? What do I need to do now? Do I need to request ALS? Very important. If in your primary assessment there wasn't any initial treatment, when you do your vital signs, it is to see if the patient is still stable. So initially, I did the ABCs, patient okay. In my secondary, I'm doing some vital signs and comparing. Okay, still stable. Or he's now getting worse. Make adjustments. So again, I don't want to see any student or EMT come to my face-to-face, and when you're doing a primary, the first thing you're doing is checking vital signs. That's madness. Primary assessment is to address life threats. Vital signs is to identify trends. Learn the difference. All right. Now, after your secondary assessment, you have your reassessment phase. So you reassess your vital signs at least every 5 minutes, or when the patient condition changes significantly, right? If cardiac arrest occurs, perform CPR immediately or until an AED is available. Reassess your intervention, provide rapid patient transport. All right. Now, emergency care for chest pain or discomfort. Ensure a proper position of comfort. Give oxygen if indicated as needed. Depending on protocol, prepare to administer low-dose aspirin and assist with prescribed nitroglycerin. All right. Now, aspirin prevents blood clots from forming or getting bigger. That's the purpose of aspirin, right? Aspirin does not thin the blood out. That's a misconception. Can't thin out your blood. 81 milligrams chewable tablets. Recommended dose 162 milligrams. That's 2 tablets to 324 milligrams, which is 4 tablets. And it's non-enteric coated aspirin. You give it to the patient, let them chew the aspirin and swallow the aspirin. Purpose of the aspirin is it has, in this situation, because aspirin can be given for a lot of things. But in this particular situation, we're giving the aspirin because of its anti-platelet properties. So when the patient takes aspirin, it's going to stick to the platelets and prevent them from sticking to the clot so that the clot does not get bigger. Aspirin cannot remove the clot. Remember that. It just prevents the clot from getting bigger. All right, now nitroglycerin available in forms. So you have sublingual pill, you have sublingual spray, and you have the skin patch. Nitroglycerin is a vasodilator. So it dilates the blood vessels. Mechanism of action: relaxes blood vessel walls, increase blood flow and oxygen supply to the heart, and it decreases the workload of the heart, right? So, and it dilates the blood vessel, which is very important. If a patient is having a heart attack, you want to reduce the workload because the heart is already damaged. Now, one thing you have to be mindful of, because it's a vasodilator, if the blood vessels open up, the pressure inside of the blood vessel is going to drop. So if the patient has a low blood pressure, you cannot give them nitroglycerin. You can actually kill that patient. So you want to know that the systolic, the top number, is above 100 millimeters of mercury. So anything below 100 millimeters of mercury for the top number is a contraindication for nitroglycerin. Now, side effects: burning sensation under the tongue, decreased blood pressure, and the patient will complain of a headache. These are normal side effects. Don't freak out if they occur. Contraindication: systolic blood pressure of less than 100 millimeters of mercury. And you actually want your blood pressure in the range of 110 to 120. That's where you really want your blood pressure, because regardless of where the blood pressure is, the blood pressure is going to go down. So you need to leave enough space for that blood pressure to fall. You don't want the blood pressure to drop below 90 millimeters of mercury. That's not sufficient for good cardiac output. If the patient has a head injury, no nitroglycerin. If the patient is on erectile dysfunction drugs and they have taken that drug within 24 hours, no nitroglycerin. If they reach the maximum dose, which is usually 3 tablets, no nitroglycerin. If it is within your protocols, and I've started to teach EMTs how to obtain an ECG, right? So at this stage, I don't expect you to know how to read the ECG, but you should know the practical procedure, how to put on the electrodes on the patient and obtain the ECG via ECG machine or cardiac monitoring. For an ECG to be reliable and useful, the electrodes must be placed in a consistent position. Basic principles should be followed to minimize artifact in the signaling. So a cardiac monitor can do two things. Well, it can do several things. But as it relates to the heart, you can have dynamic cardiac monitoring, which you're watching the rhythm in real time, or you can acquire ECG, which captures the electrical current of the heart and prints it out on a graph paper. And these are procedures that the EMT can perform. Right, now guiding principles. You may need to shave the body here. You rub electrode site with alcohol swab before application. Attach electrodes to ECG cables before placement. Confirm electrode placement. Now, the diagram that you're seeing on the right represents cardiac monitoring. So with cardiac monitoring, it is 4 electrodes. No, what am I talking about? The diagram that you're seeing on your left, the diagram that you're seeing on your left is cardiac monitoring, and it's 4 electrodes: white, black, green, red. Even though it's 4 electrodes, we can only see 3 leads. So again, even though it is 4 electrodes that we're using for cardiac monitoring, sometimes it might say 5 in the hospital, you can only see 3 limb leads, lead 1, 2, and 3. So what you need to know at this point, because I don't want to get too technical with this, we're going to come back to it. But what you need to know at this point with cardiac monitoring, it's 4 electrodes, but 3 leads. 4 electrodes, 3 leads. Remember that. On the right side, you're seeing a 12-lead ECG placement. Now with a 12-lead ECG, it's actually 10 electrodes. So it's 10 electrodes, but we use 10 electrodes to create 12 leads. Again, with a 12-lead ECG, we're only using 10 electrodes. The four leads for cardiac monitoring: white, black, green, and red, and then the 6 chest leads. That's 10. But we're using the 10 leads to create 12 because of augmentation. Don't think about it too much now. I'm going to come back to this later on. So I'm going to come back to this again. Don't worry too much about it. What I want you to note for your 12 lead is that it's 10 electrodes that is giving you the 12 leads. And for your cardiac monitoring, it's 4 electrodes, but we can only see 3 leads. Full stop, going forward. So when you come in the class setting, you'll understand a bit further, and when I go back to it, you'll understand a little clearer. Once electrodes are in place, switch on the monitor, print a sample rhythm strip. If the strip shows artifact, confirm electrodes as firmly applied and the cable is plugged in. And it's something that I will start to test my EMT students on, because it's an expectation now for EMTs. And most recently, I've had a EMT working with me at a particular location, and one of the requirements is he has to be able to do the 12-lead ECG. So yes, something that you must learn, and it's something that I will test you on. before I move on, let me just. So the difference, one of the fundamental differences between the cardiac monitoring and the 12-lead ECG is the cardiac monitoring is giving you a limited view of the heart because it can only give you 3 leads. So you're not seeing the entire picture of the heart. The 12-lead ECG gives you a more detailed picture of what is occurring in the heart. So naturally, the 12-lead ECG would be more beneficial for a patient that you suspect is having MI, a critical patient. Any patient that's critical, a 12-lead ECG will be beneficial because it's showing you a clearer picture of how the electrical impulses are moving within the heart. All right. Now, heart surgeries and cardiac assistive devices. Many open heart operations have been performed in the last 40 years. You have the coronary artery bypass graft, which basically they are creating an alternate route for blood flow. Can come from the chest or leg blood vessels, and it is sewn from the aorta to the coronary artery beyond the point of obstruction. So they are bypassing the point of obstruction. There is percutaneous transluminal coronary angioplasty. It's a very big word, but basically what it means is they're pushing something inside the artery. Think of it as like an umbrella, sliding an umbrella into the artery and then opening that umbrella to widen the artery that you can remove the clot, that the clot can be removed that is inside of that artery. Patients who have had open heart procedures may or may not have long chest scars. Treat chest pain in a patient who has had any of these procedures the same as a patient who has never had heart surgery. Some patients have implanted cardiac pacemakers to maintain a regular cardiac rhythm and rate. So some persons, their pacemaker, the SA node, does not work well. So they have an implanted device that paces their heart rate and keep it at the optimum range. Cardiac pacemakers maintain regular cardiac rhythm and rate. They deliver electrical impulse through wires in direct contact with the myocardium. Implanted under heavy muscle or fold of the skin in the upper left portion of the chest. And you will see it. You're going to see that bulge on the left side. It's not a big device, but you will see it. Cardiac pacemakers. This technology is very reliable. Pacemakers malfunction can cause syncope, dizziness, or weakness due to an excessively slow heart rate. Transport patients promptly. Some patients have automated implanted cardiac defibrillators used by some patients who have survived cardiac arrest due to ventricular fibrillation. Monitor heart rhythm and shock as needed. So the device will pick up a shockable rhythm and deliver the shock if needed. Treat chest pain patients with these devices like other patients having an AMI. Electricity is low, so it will not affect rescuers. The external defibrillation vest is a vest basically. A vest with built-in monitoring electrodes and defibrillation pads worn by the patient. Attach a monitor, use high energy shocks, do not touch the patient if the device warns it is about to deliver a shock. Vest should remain in place while CPR is being performed unless it interferes with compressions. Left ventricular assist device. Now, this device is basically a device that acts as the patient's heart. It basically circulates blood within the patient's body. You're going to see this in patients who are awaiting heart transplant. So they need a heart transplant. So this device circulates the blood for this patient. This is a patient in which you will not feel a pulse. You're not going to feel any pulse. When you listen to their heart, it sounds like a engine humming. So they don't have a heartbeat because their heart is not working. Used to enhance the pumping of the left ventricle. Most common ones have an internal pump and external battery pack. Most patients will not have a palpable pulse. Doesn't mean that they can't, but most of them won't. Transport all supplies and battery packs with the patients. And usually these patients can tell you everything about the device. All right, now cardiac arrest. Cardiac arrest is the complete cessation of cardiac activity. Absence of a cardiac pulse, absence of a carotid pulse, absence of breathing should be present. Was terminal before CPR and external defibrillation were developed in the 1960s. High quality CPR, early defibrillation, and access to advanced care can improve outcomes. All right, now the automated external defibrillator. You need to be familiar with whichever device you are using, so you need to be familiar with your device. The device needs to be checked on a daily basis. Remember, the purpose of the AED is to provide electrical shocks that is going to override the chaotic electrical activity. So the whole point of CPR is to buy time until the AED is available. All right, now AED models all require some operator interaction. However, they are easy to use. Just turn on the AED, follow the instructions. So most have a computer voice synthesizer advising steps to take. Most are semi-automated. Turn on the AED, follow the instructions. Advantages of using an AED: quick delivery of shock, easy to operate, ALS providers do not need to be on scene, remote adhesive pads are safe to use, larger pad area equal more efficient shocks. Other considerations: not all patients in cardiac arrest require a shock. All patients in cardiac arrest should be analyzed with an AED. Asystole indicates no electrical activity. That's a flat line. Pulseless electrical activity. Now this one, pulseless electrical activity, this is a patient who presents with an organized electrical activity on the cardiac monitor, but there is no pulse because they have a block. It can be a coronary thrombus or it can be a pulmonary embolism. But the electrical activity is fine, the blood is just not moving. That's pulseless electrical activity. Know the difference. So asystole is the rhythm, is a flat line. So this is no electrical activity present. It represents the absence of electrical activity. A PEA, or pulseless electrical activity, means that the electrical activity is fine, but there is no pulse because something is blocking the circulation. Now, early defibrillation. Few cardiac arrest patients survive outside a hospital without a rapid sequence of events. So these are the events that need to occur, the chain of survival. early recognition. So somebody need to recognize that a patient is in cardiac arrest and then activate EMS response. Once they activate EMS response, if it's a proper EMS system, they are going to get a dispatcher, and the dispatcher is going to give them instructions on how to perform lay person CPR until EMS arrive. This is extremely important. Lay person CPR until EMS arrives. If they're in an area where a defibrillator is available, they can access it as a layperson. Once EMS arrive, whether it's basic or advanced, they will now build on that. So they're going to build on what the civilian has done up to that point. Then they will transport if necessary, and then in the hospital, the patient will get definitive care and post-recovery care. All of these chains are necessary. So if you get a call to a location for a cardiac arrest patient, and when you go, nobody is doing CPR, it's very unlikely that that patient is going to survive. The other thing that you may also observe, which I'll show you a couple of these videos as we go deeper into the course, is that the persons that are there, they're not doing CPR properly. Again, that significantly reduces the person's chance of surviving. If your unit respond for a cardiac arrest patient and there is no AED, that's going to reduce the patient's chances of survival. So the chains need to be present, and this is something we need to fix in Jamaica. It is woefully inefficient. Woefully inefficient. And when it comes to running a code, it's very difficult. It's extremely difficult for two responders to effectively run a code in the field. So what should be happening in Jamaica? If it's a private service that you're working with, that private service should be able to request assistance from the fire brigade. If the fire brigade is responding, they should be able to request assistance from a private service. It's very difficult for two persons to effectively run a code, right? So again, the chain of survival: early recognition, activation of EMS, immediate high quality CPR, rapid defibrillation, basic and advanced EMS, basic and advanced EMS, ALS and post-arrest care recovery. Early defibrillation. CPR prolongs period during which defibrillation can be effective. Has resuscitated patients with cardiac arrest from ventricular fibrillation. Non-traditional first responders are being trained in AED use. So lay persons are now being trained. EMRs are now being trained because the sooner the patient can get the AED, the better. All right, now ALS and post-arrest care. So if ALS and post-arrest care is going to be occurring, this is what it will include: continuing ventilation, maintaining oxygen saturation, assure the blood pressure is above 90 millimeters of mercury, targeted temperature management upon arrival to the hospital, advanced assessment techniques and intervention. Recovery may take a year or longer. Integrating the AED and CPR, work the AED and CPR in sequence. So whichever organization you're working with, you have to do simulation practice every 3 months. We're not going to get cardiac arrest every single day. So you have to have some type of mechanism in place to ensure that when it does happen, your gaps are limited. So if you're not practicing something, you're going to have a lot of gaps. Your coordination is going to be off. You're going to forget that you need to be doing this, or you're going to forget that you need to be doing that. Patient suffers at that point. So simulated practice is necessary. Ongoing practice is necessary. The type of team practice must be very clear. So it needs to be clear that it's a 2-man team, 3-person team, 4-person team. That must be clear. Designated tasks must also be clear. You're a ventilator, I am a compressor, this person is going to use the AED. All of this must be clear. Protocols must be clear in terms of how long you can remain on the scene, what should happen if the patient code in the back of your ambulance, because you can't use an AED in a moving ambulance. So you need clear protocols. So the practice will incorporate work the AED and CPR into sequence. Do not touch the patient during analysis and defibrillation. Very important. So you cannot touch the patient when the AED is analyzing, because it's going to pick up your rhythm or whoever is touching the patient. And you cannot touch a patient when it's delivering a shock. You might end up with more than one patient at that point. That's 360 joules. CPR must stop while the AED performs its job. So whoever comes with the AED is in charge. Whenever they want CPR to stop, it will stop. And you do not stop CPR until the AED's pads is on the patient and it's ready to analyze the patient. So when it's ready to analyze, stop CPR. That's when you stop. Now, AED maintenance, maintain as manufacturer recommends, read the operator's manual, document AED failure, check equipment daily at the beginning of shift, ask manufacturer for maintenance checklist, report AED failures to manufacturer, and use food and drug administration guidelines. Your medical direction should approve written protocol for AED use. I cannot overemphasize this. You need written guidelines that will guide what you do when you're doing CPR out there on patients. Continuing education with skill competency review is generally required for EMS providers. That's a must. That is a must. All right, now emergency medical care for cardiac arrest. Preparation. Make sure the electricity make sure that the electricity injures no one. Do not defibrillate patients in pooled water. Do not defibrillate patients touching metal. Carefully remove nitroglycerin patch if present and wipe with a dry towel before shocking. Shave hairy chest to increase conductivity. Determine the NOI and or MOI. Call for ALS assistance in a tiered system. And this is a flow chart for cardiac arrest. You can look at it once time allows. Begin chest compressions and attach AED as soon as available with witness cardiac arrest. Follow local protocols for patient care after AED use. After AED protocol is completed, one of the following is likely: pulse is regained, no pulse regained, and no shock advised, no pulse regained, and shock advised. Wait for ALS and continue shocks and CPR on the scene. If ALS is not responding and protocols agree, begin transport when the patient regains a pulse. 6 to 9 shocks are delivered. AED gives 3 consecutive messages every 2 minutes of CPR advising no shock advice. And the standard guideline is, if you're going to be doing CPR in a moving ambulance, the recommended standard is you should be using a compression device. So you physically doing CPR in the back of an ambulance does not do much for the patient, and it's putting the responder at risk. The recommended standard is to have a compression device. Cardiac arrest during transport. Stop the vehicle, begin CPR if AED is not immediately available, call for ALS support, analyze rhythm, deliver shock, if indicated, and resume CPR. Continue resuscitation per local protocol. Coordination with ALS personnel. If AED available, do not wait for ALS. Use the AED. Notify ALS of cardiac arrest. Do not delay defibrillation. Follow local protocols for coordination. Management of return of spontaneous circulation. Now, return of spontaneous circulation doesn't mean that the patient survived. It just means that their circulation is back. This patient might still not wake up. A lot of persons believe that when they get back a pulse in the field, the patient is going to survive. It does not mean that the patient survived. It just means that circulation is back. Until brain function return, we're not sure if this patient is going to survive. Monitor for respirations. Provide oxygen by a bag mask device at 10 breaths per minute. Maintain SpO2 between 95 and 99%. Assess blood pressure. See if the patient can follow simple commands. Immediately begin transport if ALS is not en route per local protocol. And that would bring us to